Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 26th episode of Optometry series. Thank you all so much for your continuous support. I take this opportunity to thank my teammates, Ms. Anshika ma'am and Ms. Meenakshi. Thank you both so much. Dear all, the topic for today is Keratoconus contact lens fitting, and I'm very happy to welcome our moderator, Mr. Yuvraj Kalra, sir. Hi, sir. Thank you so much for joining us as moderator today, sir.
It's my pleasure to be here on such a precious platform. Thank you.
Thank you, sir. Thank you so much. I request our MC, Ms. Padmashri, to introduce and to give us more insights about the moderator.
Good evening, one and all. I'm Padmashri, studying first year optometry at Dr. Rawal's Institute of Optometry. It gives me great pleasure to introduce to you our esteemed moderator for this evening, Mr. Yuvraj Kalra. Sir is a distinguished professional with diploma and bachelor degree in optometry. He is also a fellow of International Association of Contact Lens Educators, which speaks volumes about his expertise in specialty contact lenses. With a commendable 17 years of experience, he has dedicated his career to serving the community with excellence in optometry care. His area of specialty include specialty contact lenses, low vision management, customized artificial eyes, and dispensing. In addition to his clinical work, he has contributed significantly to the field through academia. He served as a visiting faculty member for 4 years, imparting his knowledge and nurturing the next generation of optometry professionals. Currently, Mr. Yuvraj Kalra has an optometry clinic and two optical showrooms in Nagpur, furthering its mission to provide accessible and high quality eye care services to the community. Its dedication to advancing the field of optometry extends beyond the clinic walls. Mr. Karna has been a prolific presenter, sharing his insights and research at numerous state and regional ophthalmologist conferences in Maharashtra. In total, he has presented an impressive 6 papers at state level and 5 papers at regional conferences, solidifying his reputation as a thought leader in the field. With a passion for innovation and commitment to excellence, Mr. Yuvraj Kalra embodies the spirit of progress in optometry. Please join me in extending a warm welcome to our distinguished moderator. Thank you so much for joining us with us, sir.
Thank you.
The presenter for today is Mr. Shandeep Sudhir, studying second year masters in optometry at Dr. Agarwal's Institute of Optometry. Me, Sandeep, please start your presentation.
Thank you, Padmashri. So today's topic is about keratoconus and contact lens fitting. Myself, K. Shandeep Sudhir from Masters in Optometry Second. So keratoconus. The word keratoconus derives from the Greek word keras, means cornea, and conus means cone, which together means cone-shaped cornea. It is a chronic bilateral, non-inflammatory ectatic disorder characterized by irregular astigmatism, progressive steepening, changing apical scaling. The onset it occurs from at puberty. Epidemiology. Patient experience a significant visual impairment, irregular astigmatism, and high myopia. The worldwide prevalence of this condition is estimated to be 1.38 per thousand. Associations. Ocular association. Chronic eye rubbing. Retinitis pigmentosa. Aniridia. Blue sclera, and congenital cataract. The systemic association includes Down syndrome, Marfan syndrome, and Ehlers-Danlos syndrome. The pathophysiology, progressive thinning and ectasia, which occurs as a result of defective synthesis of mucopolysaccharide and collagen tissues. The clinical features include symptoms. In the symptoms, we can see as blurred or distorted vision, ghosting images, monocular diplopia, colored halos, and frequent changing of spectacles. In the signs, we can see central corneal thinning, scissoring reflex, distorted uh, or irregular keratometer myas, oil droplet reflex, acute eye drops, prominent corneal nerves, flushes ring, Vogt striae, and Bunsen signs. And these are the signs. Uh, this is oil droplet reflex. This is acute eye drops. This is corneal nerve. Uh, and then this is Vogt striae, and this is Bunsen sign. This is a flushes and the gradings. Based on the K reading, we can classify it into three types: namely mild, less than 48 diopters, moderate, 48 to 54 diopters, and severe, more than 54 diopters. Based on the morphology, we can classify into three, three types. The nipple cone, which you can see in this picture, the oval cone, and the globus. Nipple cone, it diameter is around less than 5 millimeter. It located in the central or paracentral of the cornea, commonly in the inferior nasal cornea quadrant. The oval, its diameter is around 5 to 6 millimeter. It often displays inferiorly. The keratoglobus, you can see here, the overall steeping, it has overall steepening. The diameter is more than 6 millimeter. Here, the 75% of the cornea gets affected. So the investigations we took for we can get, that is vision and refraction, keratometry, corneal topography, pachymetry, specular microscopy, and anterior segment institute. So the management can be give for the keratoconus is spectacles. Mild keratoconus can be corrected with the spectacles. The contact lens. In the early stage, we can prescribe soft toric lenses. Moderate to severe stages, we can prescribe RGP or rose scale lenses. In the severe stage, we can prescribe scleral lens or piggyback lenses. There are some ways in the surgical methods can be used. Corneal collagen cross-linking riboflavin, deep anterior lamellar keratoplasty, penetrating keratoplasty, and intracorneal ring segment and CAS. Contact lens in keratoconus. The main goal of fitting contact lenses is to improve visual acuity with comfort without compromising the health of the cornea. Barrett al. had shown that the corneal scarring can be reduced by modifying the contact lens fit. The contact lens options for keratoconus are soft toric, RGP lenses, scleral lenses, rose-scale lenses, piggyback system, and hybrid lenses. So the parameters which should be needed for the fitting a contact lenses are base curve, diameter, and power. So the lens choices would be three types: corneal, corneoscleral, and full scleral. Corneal, its diameter around 8 to 12.5, and the corneoscleral is 12.5 to 15 mm. The full scleral may be mini scleral or large scleral. Soft torics. Soft spherical or toric contact lenses have a very limited role and are indicated in the early keratoconus. These lenses can be prescribed with glasses over contact lenses. Sometimes high myopia is associated with keratoconus and soft contact lenses are useful in these patients. The other indications for soft contact lenses include intolerance to RGP lenses and discomfort with RGP lenses. Rigid gap permeable lenses. Corneal RGP is the lens is the first lens of choice for visual improvement. It is cost effective, easily available, and suitable for mild to moderate keratoconus. It rests on the apex of the cone. So the fitting philosophy may be classified into three: apical clearance, apical bearing, or 3-point test. So this is the apical clearance. Here the central fluorescent pooling and thin edge clearance is visible. The fit should be modified using a flatter base curve. The apical bearing. Central bearing can be seen as a dark area because of lack of fluorescence in this area with thin edge clearance at 3 o'clock position. This can result in the staining in the same area. So diffuse fluorescence in the center and mid periphery on either side depicting the divided touch or 3-point touch. Rose scale lenses. Then the cone is a central nipple cone. A rose scale lens can be selected. These lenses are merged curve lenses with a small optical zone which snugly fits the cone, so called as a feather touch to the cornea. The company recommends the selection of first trial lens to be 0.2 mm steeper than the average K for the mild to moderate K values. For advanced, the average K values are between 5.1 to 6 mm. The first lens to be applied should be same as the average K value and 0.3 mm flatter than the average K in the severe cases. Type of rose scale lenses. Rose scale 2 lens with front surface aberration control providing superior vision. Rose scale 2 soft irregular corneas. Rose scale 2 irregular cornea lens for larger areas of corneal distortion. Rose scale 2 post graft PG lens for post corneal surgical cases. Rose K2NC specifically for nipple cones. Rose K2 XL corneous clear lens, which is ideally suited for the patients who cannot tolerate smaller GP corneal lenses. For pellucid margin degeneration, keratoglobus, corneal inserts, and the patient who has significant corneal distortion after undergoing penetrating keratoplasty. So the primary indications, the rose K2 they can give for oval keratoconus, rose K2NC nipple cones, rose K2IC for pellucid marginal degeneration, keratoglobus, LASIK induced ectasia and postgraft. Rose K2PG we can give for the patients who have undergone penetrating keratoplasty. The parameters, the base curve, sorry, the base curve can ranges from 4 to 8.8, and it can for the rose K2IC 5.5 to 9.3 mm. Steps in fitting the rose K lenses. Step 1, the base curve selection. Select the base curve which yields the best visual acuity, fitting as flat as possible. Peripheral fit. Adjust the periphery to optimize lens fit, location, and movement. Diameter. The edge of the lens should be extended approximately 1.5 mm beyond the limbus. Location. The lens should be centered equally around the limbus. Movement. On blink, approximately 1 mm of the movement should be observed. Uh, So the indications, it can be for K reading 7.1 mm flattest, select the first lens 0.2 mm steeper than mean K reading. For mild to moderate or rose K2NC, we can see the select the first trial lens 0.2 mm steeper than mean K. For rose K2IC, select the first trial lens 0.3 mm flatter than steepest corneal meridian. For rose K2PG, select the first lens 0.3 mm steeper than average K reading. So these are the optimal fit. And this is the rose K2 lens. We can see the optimal fit immediately after the blink. In the NC, we can see it is a nipple cone. It is the optimal fit we can see. The rose K2IC 11.4 mm diameter lens in pellucid margin degeneration. Optimum apical touch and edge lift is seen. Rose K2PG, here you can see the optimum fit. So the scleral lenses. The two scleral lenses rest on the sclera and do not touch the cornea and limbus, leaving a clear area between contact lens and the cornea. It is a larger diameter lenses. It can be used in keratoconus and keratoglobus, pellucid margin degeneration, post-classic or PK corneal graft. The fitting. We need to assess the scleral landing zone, determine the apical clearance, determine the limbal clearance, landing zone alignment, edge lift, and over refraction. So these are the central value vaulting, limbal vaulting, and the edge relationship which seen in the scleral lens fittings. Piggyback and hybrid lenses. Piggyback lenses, it includes two lenses. One is RGP placed on the soft contact lenses. Indications for the irregular corneas where RGP lenses fitting are not possible, such as keratoconus, PMCD, post-graft and post-elastic ectasia, and also in patient with RGP discomfort or intolerance, unstable RGP under eye, popping out of the lens, 3 and 9 o'clock staining with RGP, fit and presence of scar. Hybrid lenses have a rigid lens in the center and a soft skirt in the periphery. The most recent introduction in hybrid lens is the Synerge Ice lens. So this is the rigid lens and this is the soft lens. So thank you for giving me this opportunity.
Thank you so much, Shandeep. That was a wonderful presentation.
Thank you, ma'am.
Yes, now I request Yuvraj sir to share his valuable points about the topic, sir.
Good job, Sudhir. It was nice presentation. Good data to hear. One thing I wanted to ask
Thank you,
you,
sir.
from where you got this 1.38 in 1,000 people, from where you got this data? This is global data or Indian data?
This is a global data, sir. I got it from an article.
Okay, global data. And
Thank you, sir.
when this research was conducted, do you know? I mean, I'm
Uh,
asking for more. No, I'm on because when we started 20 years back, it was way less. But definitely from 15 years, I'm practicing keratoconus patients. So the incidence keratoconus have increased, and other perspective, what I see in getting new patient is uh, the involvement of technology, the usage of topographer, and awareness of ophthalmologists have increased. This is one of my opinion. They have the people mostly nowadays we get keratoconus patients who are rejected from LASIK.
yes, sir.
They go for LASIK, they go for topography or pentacam. When they come to know, I mean, at that time, they come to know that they have keratoconus and they cannot go for the LASIK, so they go for the keratoconus treatment.
Keratoconus. Yes, sir.
Earlier days, when people were not very keen to go for the LASIK, they were not even getting tested. And other thing, even ophthalmologists who were checking the patients were not very much keen to diagnose or to do topography to investigate in such kind of cases. So
Yes,
incidents have increased globally, that we also understand. I mean, I agree to it, but one more, what I feel is diagnosis or the correct diagnosis ratio has increased. So we are
okay, sir.
getting more number of patients. Uh,
Yes, sir.
am I right, Anshika? Do you also feel same?
Yes, I feel after the use of technology, we are actually getting more of keratoconic patients than we used to get it before. That is also one of the increase in keratoconus that we have seen in.
I remember before 2012, I'm talking about Nagpur, in such a big city like Nagpur, we had only 2 or 3 topography machines.
Mm.
Now we have almost around 15 to 20 in a
Okay.
city, right? So just imagine in 2 topography machine, how many patients were tested, and those 2 or 3 were at LASIK center only.
Okay, sir.
Right. So that is one more reason. And other is Sudhir, uh, definitely piggyback lenses you spoke about. Nowadays, piggyback lenses are not practiced.
Yes, sir.
Very rarely. Very, very rarely. It's almost obsolete, like PMMA lenses. Because now we have better options like hybrid lenses and mini scleral lenses. So, from patient's point of view and from practitioners' points of view, mini scleral lenses are the first choice for the comfort of patient. When
Yes, sir.
it's not working and the patient is not indicated, I mean contraindicated for mini scleral or corneoscleral, then only we think about hybrid lenses. And piggyback is gone. It's just definitely you have textbooks, you
Yes,
have
sir.
piggyback lenses in textbook, but in current practice, it is not being used. It is just to inform you,
Okay, sir.
right?
So,
Okay, sir.
what are, Yuvraj, according to you, what should be the fitting parameters as an optometrist should look for when you are fitting for a keratoconic patient?
The basic utmost prior thing is K readings. The accurate K readings are very, very important. And the type of lenses you are fitting, the parameter selection depends on that. The whichever company you're using, I mean, whichever company's trials that you're using for the fitting, they provide you the guideline. There is no fixed rule for every lens. Every trial set, every lens design has a different fitting criteria, right? So, talking about GP lenses, if I'm fitting X brand GP lenses, they ask me to do first trial lens selection based on the average K, right? But the same size lens, size in the sense diameter. I'm not changing the diameter. If I'm talking about the 9.2 mm, so other companies 9.2 mm, they recommend to go on the flatter K. So that all depends on the company's profile, whatever lens you're using. So always in GP lenses, and especially in keratoconus fittings, if you're doing, definitely you need to stick to the theory, but theory doesn't work in practical. Every keratoconic eye will behave differently.
Do you have any
Got it?
complications that you have seen post contact lens use in keratoconic patients?
Definitely GPC, GPC, mild ptosis and prolonged wear in GP lenses, not many scleral. In GP lenses, mild ptosis have been observed. And in some of the patients who have nipple cone or low riding cone, they have the habit of chin elevation.
So,
This
Meenakshi,
is physical changes.
okay. Meenakshi, do we have any questions from the YouTube live?
Hello, ma'am.
Or
Hello, sir.
uh, I wanted to share my presentation also, if time permits.
Yes, yes, definitely,
I
sir.
want to elaborate on Sudhir's talk.
Definitely.
Can we do that?
Yes, sir, we can do that. Gomati, can you have share screen access?
Yes, ma'am.
Can you see my screen?
Yes, sir. It is getting shared. It is showing that you have started a screen sharing.
Pardon?
It is showing that you have started a screen sharing.
But
Yes.
I'm not able to see any picture, Yuvraj. Yeah.
Yeah. Now it is clear, sir.
Is it visible now?
Yes, sir. Visible.
So these things he has already covered, so I won't be taking the time.
Sir, sorry to interrupt, but the slide is
Yeah.
not moving.
It's not moving?
No,
Yeah.
sir.
Still?
Try changing the slide, sir. Yeah, sir. Now it's fine.
It's fine.
Yes, sir. It is fine.
Keratoconus, GP lenses. Am I audible?
Yeah, sir. You're audible.
Yeah. Yeah. In contact lens fitting, what we do in our daily routine activities, we are not bothered much bothered about the quantity of visual improvement. We don't target 6 by 6 or 6 by 9 or 6 by 5. Our main concern for the patient is quality of vision. No matter if he has 6 by 9 for the routine activity, for his daily activities, daily life, 6 by 9 is also good. But make sure the quality of vision should be very good. Contrast sensitivity should be very good. There should not be any ghosting of images. So that is very, very important. And mostly if you are fitting properly with the GP lenses or mini scleral lenses, they will take care of it. Right? And key points and successful fitting in keratoconus especially, reasonable patient motivation. If patient is not motivated enough to wear the lenses, no matter how best vision you provide, how best comfort you provide with the best lenses, he is not going to wear it. So always make the patient motivated first, right? And the patients and practitioner and patient both, because one patient for the keratoconus in GP lenses might take 40 to 45 minutes, and for mini scleral minimum 2 to 3 hours, almost 2 to 3 hours it takes. So you both have to have a lot of patience to get the right fit and the perfect fit, right? And always when you start keratoconus fitting, don't rely on one trial set. Always have access to different kind of lenses, because from my last 17 years practice, I haven't seen that one trial set will fit all, right? So always keep different kind of designs of lenses and different types of lenses. Apical bearing and apical clearance you spoke about, Sudhir. But one more thing I want to add it to, apical bearing is not at all advisable nowadays because it might damage the patient's cornea, right? And these are the picture after apical bearing fitting.
Yes, sir.
Can you see the central corneal scarring?
Yes, sir. Yes, sir. You can see.
Yeah, just calculate if a patient is blinking 15 times per minute. So how many times, I mean, if he is blinking, with each blink, the lens will move on the corneal apex, right? So just calculate in one day how many times that lens will provide friction to the cornea. And such a sensitive and delicate structure like cornea, how will it remain transparent after so much of friction every day? Apical clearance is also okay, but not very much comfortable because excess apical clearance may lead to corneal hypoxia. So always keep a watch that you are not crossing the line, right? This is the
Yes, sir.
clinical picture, clear picture of apical clearance. Right, 3-point touch, though it is actually a 3-point touch is our target, our dream in contact lens fitting in keratoconus, but ideally speaking, very few times we get that 3-point touch. The only thing we need to consider is 3-4 things we need to finalize before dispensing the lens. The visual quality should be good, vision quantity should be good, corneal health should not be compromised at any cost, and patient should be comfortable in wearing lenses for the whole day. Right? Don't run behind the 3-point touch. In some of the cases, you are not going to get it at any cost, the best lens you try. So our main aim should be these 4 things: good visual quality, good visual quantity, good corneal health, and minimal trauma to the cornea, right? And patient should be comfortable whole day. This is the picture. This was taken at my clinic. Uh, I hope you people know how to assess the fitting. Do you want me to go on this?
No, sir. Actually,
No,
it
sir.
will be fine only.
No?
Already,
No. Yeah, 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 done. Right. Yeah, mini scleral and corneoscleral designs. These two things are different. I mean, these two lenses are very much different from each other, right? So the corneoscleral lenses are the one which falls in this category, 12.6 to 15 mm dia. The bearing is distributed on the cornea and sclera both. And mini scleral is more than 15 mm to 17.9, and large is, which is actual the scleral lens, that is more than 18 mm. But in our routine practice, we hardly need large scleral lenses in keratoconus. Most of the patients are covered in this either corneoscleral or miniscleral category. Advantage of miniscleral lenses are, you must have read all this. This is the fitting goal. It walls the cornea. So the best thing is when you explain it to the patient, always say best is to stay away from the cornea because your cornea is already compromised. So the more you stay away from the cornea will be healthier for the whole life, right? So many scleral lenses are the best option in such cases where corneal apex is centrally located or inferiorly located, right? This is the clear picture from IACL for the calculation of clearance. Apical clearance, this is what we observe and what we measure initially when you fit the lenses, and in the evening hours when you observe, there'll be less apical clearance than what you fitted in the morning, right? So minimum you need to observe that even after the complete sinkage, it should not cross, it should not be less than 150 micron, right? It takes a lot of practice to calculate the clearance thickness. I mean, thickness of saline between the cornea and lens. One case I want to discuss with you. This is application bubble. Always when you are dispensing the lens, explain the patient the significance and or the danger of air bubble, right? Because sometimes this can be dangerous and patient don't take care of it. They wear the lenses with the bubble. This is a patient, 20 years old male with bilateral keratoconus. His chief complaint was blurring of vision, itching, and irritation and redness. History of chronic VKC since 1 year and keratoconus since 5 years. VKC he had from his childhood, but from last 1 year it was very severe. So it was not tolerable. So he was rushing to the hospital here and there. The visual acuity was CF 2 meter in the right eye and left eye was 624. So the referring ophthalmologist planned right eye dark and left eye miniscleral lenses, which I opposed. I don't recommend corneal transplant until lens fails to serve the purpose. You can see the picture. This is right eye and this is left eye. This is corneal curvature, 64.5 and 74.1 in the right eye. We did the contact lens trial. It was done with the silver line CSL, corneoscleral lenses. For the right eye, it was 7.2 base curve. SAG was 4.37 and left eye it was 7.5 and SAG was 4.09. The visual acuity improved up to 6 by 12 and 6 by 9. See, can you people see the corneal shape here? How distorted it is?
Yes.
Yes, sir.
Right? So you can imagine the severity of keratoconus in this case. This was the lens fitted. There was no change. It was well-centered lens. This patient was fitted in 2019 December, right? He's still doing fine. We changed the lenses last year. Almost he won this lens for 3.5 years to 4 years. And he was comfortable till last day. except routine lens change, there were no problem. These were the final parameters. And left eye, we planned C3R. And after C3R, we did the fitting again. And now he is wearing the lenses in the left eye also. So my major concern, major idea for presenting this case was, when ophthalmologist or people recommend corneal transplant in such cases, always take a stand, do your best, avoid the surgery, because transplant is not a very good option for every patient. It's not very easy, right?
Yes, sir.
Thank you so much, sir. Am I audible, ma'am?
Yes, Meenakshi, audible.
So thank you so much. The presentation
Welcome.
was very detailed and explanatory. Thank you so much, sir. Gomati, can you take over
Welcome.
now?
Yes, Meenakshi, thank you so much. So thank you so much, Yuvraj sir, for joining with us today and
Welcome.
sharing so much valuable points. We are so happy and glad to have you
Welcome.
here.
Welcome. My
We would like,
pleasure.
yes, we would like to have you in another wonderful platform, sir.
Thank you. I'll be happy. Yeah, anything more? Any of the student want to ask something?
No, sir. Actually, it's an exam season at DIO. So students are not
Okay.
able to join on live today, but we'll be giving them modules.
Okay.
So they'll be submitting to us later.
Okay. Whenever they want to ask something, you can. Thank you.
Thank you, sir. Thank you so much. Anshi ma'am, would you like to add any points?
No, I will just like to summarize what he said, that in Keratoconus fitting, vision quality, vision quantity, no injury to the cornea, and fitting goals is something which we should really concentrate at. So it was a very detailed view of your side, from your side, Yuvraj. Thank you so much for giving us all the inputs, which will be very helpful for us, even us as practitioners, to fit keratoconic corneas.
Thank you. Yeah.
Thank you so much, Anshi ma'am.
So,
yes, sir.
yeah. So shall we take a leave now?
Yes, sir. Thank you. Thank you so much, sir.
Thank you.
I'll just wind up the session. Thank you. Dear audiences, thank you all so much for your continuous support towards Optometry series. If you like this video, give a thumbs up and share this with all your friends. To know more about the updates at Dr. Agarwal's Institute of Optometry, please do follow our Instagram, Facebook, and LinkedIn pages. The links will be given in the description box. Thank you all so much. Meet you all in the next episode.